panelists, guests, friends. I'm going to start very precisely at 2 o'clock in the next 4 minutes or so. But I just wanted, before we go on live, to warmly welcome all of you. We are spread from around the world. Professor Lambo is joining us from the United States. We have some from the Philippines. We have Dr. Menaka in Anambra, and a few of us here in Lagos. Dr. Gonsalves, thank you also very much for beginning this conversation that I hope will have a salutary effect on how healthcare management evolves in our country. So welcome, and in 2 minutes I'll formally start. Dr. Idris, welcome.
Thank you.
Lovely.
Good afternoon, Prof.
Good afternoon. Mazi.
Hey, Professor Emeritus International.
I salute you. Welcome.
Can you guess where I'm located? You know those from China and UK. Do you know where I am from?
No, where are you? China.
Don't worry.
You know, if you have a room in your house with a lot of China, it can be called China.
I'm in Oshobo.
Wow.
Osun State.
That is it. Well done. Yeah, PSN has a conference there, right?
Yeah, it's starting by Monday, tomorrow it will kick off. So I arrived to get things set.
Okay, lovely.
Good to see you, Professor.
Hello, Pat.
Hi, welcome.
How are you?
I am good. You know, how are the grandchildren? You're enjoying yourself too much.
Yes, and there's a lot of celebration around here.
Oh, yeah. Congratulations on your elections.
Well, thanks. Mazi.
Yes, sir.
I saw you a century ago.
My professor, I remembered you, Natal Pat won't disclose that. I remember that there is my big chair and former minister who is hanging out somewhere. We haven't seen him for a long time.
Well, I'm on retirement.
Well, yes, we know. So that does not mean you should disappear.
We define retirement as a change of mood, change of activity. Thank you all so much.
Nice
okay, I'm going to start formally now. In 2-3 minutes. You see, Dr. Tim Menakaya is in Anambra, but looks like he's in Abuja.
Yes, I think I'm in Abuja.
You can see all the paraphernalia of Abuja.
Coat of arms. How are you, sir? Dr. Menakaya, good to see you, sir.
Yeah. It's my pleasure seeing you again, Mazi.
Oh, I thank Pat for bringing all of us together again. It's a great pleasure.
That's wonderful.
My senior colleague.
I can see Jide Idris.
My senior colleague.
My commissioner.
How are you, sir?
God is helping us.
Dr. Menakaya, my senior colleague.
Yeah, my colleague, how are you?
This is Itai Lambo.
It's my pleasure seeing you again.
Yeah, thank you very much, sir.
Fortunately, I can't touch you, but also we're not supposed to touch these days.
Right.
You see, we're COVID-19 compliant.
Yes.
No.
Idris.
Prof, how are you, sir?
Keeping out of trouble, as usual.
So, low profile. Retirement.
No, he's having a great time with the grandchildren, you know,
Oh yeah, you
one
better
after
believe
the
that.
other.
You better believe it.
Oh, yeah, that is lovely. Okay, good afternoon, good morning, uh, depending on where you are on the planet. Actually, for our friends from the Philippines, it's good evening. It is a great honor, truly a privilege on behalf of the Center for Values in Leadership to continue our conversation on Nigerian history. Permit me a couple of minutes to introduce why we have this series, how far we've come down it, and what track we're looking to travel. The Nigeria History series was started earlier this year by CVL because we realized that a lot of young Nigerians, and when I say young, I don't even mean people in their teens, including people up to 40 years old, don't know enough of the history of our country, especially in policy areas. Uh, and this is why we're repeating many mistakes that we have made in the past. We thought that if we began a series that enabled us to use the experience of people, their aspirations from time past, and the things they dealt with, to throw some more light on the challenges of implementing policy and the direction the country is traveling, we may get enough people who learn enough to act differently so that our country can be a better place, a more thriving, more prosperous society. And we have been through a number of policy areas, from foreign policy to matters of trade and development, and but the most important sector, in my opinion, are the social sectors. All human progress are denoted around how the social sectors evolve. And I have, as a particular favorite to fall back on here, a book written by Princeton University economist who won the 2015 Nobel Prize in Economics, Angus Deaton. And the book is titled The Great Escape: Health, Wealth, and the Origins of Inequality. And most people who have studied how the human race has evolved, human progress, will tell you very clearly that man has traveled so much further since the germ theory of disease enabled a focus on healthcare, um, education, of course, that has given man the ability to then create more value and improve the quality of his life. If we have not made as much progress as we should as a country, it is clearly because we have not taken the path of the Great Escape stoutly enough. We thought, therefore, that we should have a series. This is not a one session series like the other ones on foreign policy and so on and so forth. The Great Escape series will feature healthcare and education over a 6-session period so that we can properly interrogate the big challenges that we do have. We are fortunate to have a bevy of the finest to lead our conversation today. They go from a very special cameo appearance from Professor Theo Gulesi, one of the grand old masters, and his work in rural community health is one that I like to go back and refer to again and again. So I probably would like to, when I start, get him to open us with some remarks about how he has seen things evolve. And we have two former ministers of health, Professor Itai Lambo and Dr. Tim Menakaya. We have from the pharmaceutical end, Mazi Samu Huabungwa, who's current president of the Pharmaceutical Society of Nigeria. It's actually in Oshogo right now, where PSN is starting its convention. We have also with us, and this is a very important part of the track I would like to evolve, because healthcare is often imagined as a federal responsibility, whereas it really is one of the most critical things on the concurrent list. Dr. Jide Idris, who all of us admire the work he has done over a significant period of time from the public service and then the political role as commissioner, and one of his successors in the service, Dr. Titi Gonsalves, as permanent secretary in Lagos. And we can take a perspective of the relationship between the subnational and national government in managing healthcare. And they were around during the period of Ebola, which was most interesting. And we can speak to some of those kinds of challenges that we dealt with. We have Dr. Clara Ejembi also, who is part of this core panel. But we have joining us so many people, physicians, hospital managers, pharmacists, and co. And at the point, everybody will get a chance to make a contribution that they would like to. But let me begin by, as an honor to Professor Ogunlesi, ask him kindly if he could unmute himself and say to us some words about why healthcare management has gone the way that it has gone in Nigeria, from the ambitious effort that you had in Ibadan when CVL honored you years ago. We looked at the, I think Ibarakwa, is it community, the work that you tried to do there. What has been the problem? Why is healthcare management not where it should be, the way that you had dreamt it 40, 50 years ago?
Thank you very much. I thank you for inviting me to participate in the program. I will be 90 years old this year, and therefore I thank that still when this of this thing come up. I have to have someone who started it in profession from very bottom of the down. I trained at the Yale Medical, where I served as a medical staff. I moved through the scale. My classmates, my fellow Parabim, President Christopher Code, in the room came, and so.
Perhaps the video can be switched off so we can hear the voice. Maybe the network can be better with the video switched off.
University was started, it was meant to be next university. I was trying to raise the UI that by grace of God, I was part of that university in 98 because the foundation Professor Orwa Melambi, principal there, a woman, Professor Lee Alexander, who was the medicine involved.
Yes, I think
those who to start,
Prof, if those helping out can maybe switch off your video so that we can hear you more clearly. The bandwidth is kind of thin.
Go on. Okay. I'm sorry, a person operates mind around, but can I, if I now down, hear me? Can you hear me?
Yes. Yeah, if you project a little bit and we'll then, if it doesn't hold too much, we may go to Dr. Menakaya and come back.
Maybe carry on.
Okay.
Come back again.
Okay. Let me go to Dr. Tim Menakaya and basically ask this fundamental question. You know, we follow the American elections. Some of the big issues have been about access to healthcare. We know how differently things are between Canada and the United States, just across the border in terms of access. We know how extraordinary a poor country like Cuba has been effective in opening up access in number and quality of doctors providing access, and so on and so forth. Dr. Menakaya, in your experience, what have we done wrong or right in terms of expanding access? And I will take your response and segue straight to Professor Lambo, who has worked at this from perspectives including health insurance and all of that. But let us start with your perspective on what the problem has been with access in our country.
One of the greatest problems we have in Nigeria are regarded as 4 A's. The availability of the facility to have a proper medical care, the access to the place, how do you get there, and the affordability. These are the 3 major things in Nigeria that we have not looked into seriously. How do you get into it? I remember several years ago, since we are talking about history, hospitals were so scattered that people travel miles to have access to medical care. When you travel miles for the access to medical care, you can't say that the medical care is available. It is very scarce and it's meant for special people who are mobile to go to those places. You can imagine when the University of Ibadan Teaching Hospital was the only tertiary institution we had in Nigeria. People travel from Onitsha to Ibadan to have access to medical care. And that makes it extremely difficult. Today we have, but there are things that are extremely important to make sure that those things are available to everybody. And that is health insurance. Without health insurance, it can never be as properly accessible to Nigerians, because the cost will be formidable. And you know that healthcare delivery is a very expensive thing, and you don't expect government to do it all alone. So this is what is very important. For us to get into it properly like other countries, we have to consider those 3 things. Availability of the facility, accessibility of the facility, and the financial input that will come with them. They are very important. In every sphere of medical care, so many people run from Nigeria to Europe, Britain, and America to have medical assistance. They will tell you the cost. Therefore, in Nigeria, we still have a system where the rich can access medical treatment and medical help, and the poor will have nothing to do with that. That is why we have so much of quacks everywhere. There are so many quacks in Nigeria, but this is what somebody can afford. For example, if you go to a hospital and you are a child, and a nurse, even a nurse attendant, even a cleaner, has access to your prescription, you tell you, let's go. I know what they are. I'll give them to you and charge you little or nothing. And you say you have medical access, you have medical treatment. No, it is not there. So we have to go back to the drawing table and look at the health insurance we have in Nigeria and make it available to every Nigerian. It can be done, and it has done in many parts of the world. We talk about history. So we can talk about Germany. They started the most comprehensive healthcare in the world. All right. When they started, it became a political thing. So many people said, no, it's expensive, you cannot afford it, you cannot do it. But when it is completely in place, it became the cheapest thing to do, and it helped to build up the healthcare delivery in Germany. It made money accessible to everybody. This is a system by which the rich pays for the poor. You collect percentage of earning of the rich and use it to treat the poor. The poor will pay very little, and then the rich will pay more. And the person who goes to the hospital more is the poor person. The rich man lives in a good house, good environment, eats good food, has exercise, has everything. The poor has no access to all these things. Therefore, he will be sick from time to time. He will go to the hospital. He will have a family. And then you will walk into the hospital, have a treatment, and walk away. At times they say some doctors are wicked. You come there, they take a deposit from you, they do this and do that. They cannot survive if their treatment is not paid for. Therefore, if it's paid by the insurance, it will give a lot of improvement to our healthcare delivery, and it will go a long way for the country. So we should work towards that. We should have an organization or a committee of experienced people, doctors and insurers, to come together and work it out. And then the government will have little input into it. The people will pay for their healthcare delivery without bringing out money from their pocket, but they are paid for it indirectly. This is one of the problems I believe that if it's solved, the healthcare delivery in Nigeria will become very important.
Okay, well, thank you so very much. But the thing is that we have spent a lot of time in this country working on health insurance, more comprehensive one, narrow ones. I remember the late Professor Ilibute, and I guess the IGEA people had this scheme in, I guess, Kwara State with some support from the Dutch, I think. But Professor Lambo was involved during his tenure as minister in work on national health insurance. I talk to people and they are also frustrated about the whole system for a variety of reasons. Perhaps Professor Lambo can begin to put this in perspective. People quarrel about all kinds of things around the airport in Nigeria.
All right, Dr. Lambo can come in because he came in after I had left. But if you allow me to say something.
Okay, a quick one on that, yes.
Yes, I would say that this is all happened in Nigeria. When I came in, there was plan for health insurance. There was a committee working on it. But I found that labor was not involved. The labor was not involved. they were giving health insurance to those who already have full medical care, those in civil service, those in corporations that are looked after by their companies, but not the working class, not the people that live in the villages, not the people that are in the market. And what we need is a very comprehensive health care that will involve every Nigerian. And when it comes to that one, it becomes cheap. The government, the hospitals are improved, supplies are ready, are supplied every time, and it's much easier. I think
Okay.
the Colombo can now come in.
Okay.
Thank you, Pat. Can I go on?
Yes, please go on. Yes.
Yes, I think given the discussion so far, let me start by thanking you for inviting me to be part of this. It was because of you, largely, as I told you, that I accepted this. Reasons because I've talked and talked and talked, and I'm tired of talking. But at least I would like to clarify a number of things. From what your preamble and the contribution so far, there are three things. One is the evolution of the health system. Second one is the way the system has evolved over time. What have been the major problems? And I think third one is the issue of health insurance, health financing, particularly health insurance. So I don't know how much time I will have, but I think
we'll come around several times.
Okay,
but,
I want
5 minutes in the round. Yes.
Yes, I think it's good to look at the evolution very clearly first. And then we talk about the problems and focus on the health insurance.
Sure.
So if you permit me to go along that way.
Please go ahead.
Okay. Now, I like talking about the evolution of the health policy and health systems development in Nigeria. And from my own perspective, I think there are 6 phases that I have observed. The first one is during the colonial period. Due respect to Baba, Professor Ogunlesi, and I doff my cap to you, sir. You will remain great by the grace of God. During the colonial period parts, we know that the system was delivering curative hospital services. And these were largely for senior public servants and government workers. And the public health activities were mainly focused on environmental health and vaccination. And they were concentrated in urban areas. And therefore, there was very limited access to the general population except where mission facilities existed. In my area, we happen to have, it was then SIM Hospital, Egbe, which was very famous in those days. That was the only hospital that was available to us in that area. So that was the kind of thing we had up to the time of independence. Now, phase 2 was the period I call the National Economic Development Planning era. And this spanned the period of 1962 to 1985. And this is broken into 4 or 5 subphases. The first one was the first National Development Plan period, 1962-68. That was the first indigenous plan that we developed. And of course, in developing the plan, particular attention was paid to prevailing health problems. And therefore, the plan aimed at addressing those health problems. Emphasis was on health manpower development and building health facilities. And the focus of health services delivery was still curative rather than preventive, and it was urban biased rather than rural. The second subphase of this National Economic Development Plan era was during the second National development plan period, 70 to 75. Now, again, the plan aimed at improving prevailing health problems. And, we had the Civil War. We ended the Civil War at that time, and restoring, rehabilitating health facilities that were destroyed during the war. A priority was also given to environmental sanitation, but added to it was the training of medical and health personnel. The third subphase was during the third national development plan period, 75 to 80. That period marked the initiation of health system development, with primary health care as a cornerstone. And I think the major initiative at that time, at that period, was the basic health services scheme, which was introduced to increase access to services and correct the imbalances between preventive, as well as urban-rural area bias. You will recall that Professor Ransom Kuti of blessed memory was appointed as the director of this program.
Yes.
And it was really an attempt to increase access. And the BHSS, that's the Basic Health Services Scheme, was based on the concept of a BHU. BHU is a basic health unit, which was aimed or which was planned for an LGA with a population of 150,000. And for each LGA, the plan was that you will have the following facilities.
In fact, just not to interrupt you, but we plan a special session on primary health care because it's something very, very dear to my heart personally. And I have some ideas of, how local governments can focus on.
Yeah, I'll be interested in participating in that also.
All right, great.
But let me just run through this overview. Yes. It was to every local government of 150,000 was to have a comprehensive health center, 4 primary health care centers, 20 primary health care clinics, and 5 mobile clinics. Now, and then the health workers, they introduced new cadres of health workers, and these were to be trained in schools of health technology, and the CHOs, that's the community health officers, were supposed to be trained in teaching hospitals. Now, I have a lot to say on this because I was part of the program. That program failed. And even at inception, when I was invited by Professor Kuti, I told him that I know this project will fail. He asked me why, and I told him why. And I turned out to be right. Number one, just to mention, and I think I'll elaborate on this when we are discussing primary health care, is that attention was largely on, facilities, health workers. They were to be very numerous but more importantly is when I costed what we will need to be able to put this in various local governments in Nigeria, I saw that it was not affordable, given our level of resources at that time. The last, during the planning era, was in 1980 to 85. Again, that failed. Now, so really, let me go to third phase. That was the first serious effort of health policy and health systems development. And that was 1985 to 1992. Coincidentally, it was during the time that Professor Ransom Kuti became minister. And a number of things happened. He tried to implement PHC based on the Alma Ata Declaration. Did so many things, which I will say for now, for when we are going to discuss primary health care. But what then happened was that at the end of that, I was then in WHO, I remember, He was so proud of his achievement that in 1991, he wrote to WHO to please come and evaluate the progress we have made in Nigeria. And I was part of the people providing technical support to the team, high-level team. Members were drawn from all over the world. And the report at the end of the review was that Nigeria had done very well, with respect to primary health care. We got a pat on the back. And indeed, the review team said, look, you need to institutionalize the implementation of primary health care. And that was what led to the establishment of the National Primary Health Care Development Agency. Now, one of the key achievements at that time was the 80% immunization coverage that we were able to achieve. That was up to the 1992 when he ended the tenure. After 1992, we entered another phase, which was phase 4. And that was when the PHC, what he built, totally collapsed. And I'm not sure we have been able to rebuild that. When we're discussing that primary healthcare, I'll be able to adduce reasons why this failed. Now I go to phase 5. I'm almost nearing the end of this. It was the second serious effort at developing, health policy development, as well as health systems development. I would say that was the period 1999 to 2007. You had return to civilian government. You had the enactment of the NHIS decree shortly before. It was in May 1999 that the decree was enacted on NHIS. We'll come to that later. And then, of course, so many things took place. Our health sector reform agenda, which, in all modesty, I think achieved the purpose for which, we designed and implemented it. And a number of things happened. Financing by government increased. And when government increased its financing to health, the partners, increased their financing too. I remember the federal government financing of health increased by almost 150% between 2003 to 2007. And the donors almost tripled their investment. DFID particularly, their portfolio almost tripled because I was working with them before I became minister. So some progress were achieved at that time. And of course, the last era is from 2007 up till now. Ladies and gentlemen, all these efforts have been made, but we still have big problems. We still have very weak, ineffective national health system for a number of reasons, which we will come to. When we talk about the national health system, please don't equate this with health services delivery. National health system has at least 6 components by WHO definition. These are governance or leadership, health services delivery, health financing, human resources for health, health information, medicines, technologies, and vaccines. So where we are today, Pat, and that is why we're still not being able to increase access. The quality of services is still very poor, and therefore the health status indicators are very poor. There are so many factors responsible for this. 4 of them are: 1, the constitutional and legal framework for health. If you go and look at the Constitution, it's very deficient about health, the position of health. Secondly, the political leadership and the absence of putting health as a very important item in the political agenda. This was one of the things we did 2003 to 2007, preaching that at the national level, and even we went to states. But thank God, it's not because Idris is here. Lagos is probably one of the very, very few states that caught the virus and ran with the virus. I mean, you have good viruses and you have bad ones. Bad ones. This was a good one. And that's why Lagos is doing well. Kudos to you in Lagos. The third problem is policies and the implementation of those policies. It is sad to say that over the years, let me focus attention on the health, the sector I know best, which is the one we are defining, health sector. Ministers come, things change. We have had policy somersaults. And I know what we did over the 4 years. Indeed, I think one of the names I was given by people who are ignorant is to say that during our time, we developed policies and plans. Elementary management will tell you that if you want to tackle a problem, you identify what the problem is, you have a policy on the problem, you translate the policies to a plan before you start implementing. You cannot just implement. So when people say they spend time developing policies, plans, and so on, it's because they don't know Management 101. So what has been happening is that we don't build on the foundations. I mean, we don't build on the successes of our predecessors. We start from the beginning. And I think that's not only peculiar to health, it's all over the various sectors. And this will not help. And the fourth big area, part, why we are still where we are, is because of the health system. The national health system has not improved. It is still weak. It's the vehicle you are going to use in developing services, but it's very weak. The way it was before Abraham was is the way it is today. I cannot clap my hands at all. Because when you look at the components of the health system, which are governance and leadership, health service delivery, health financing, and we are going to come to that, human resources for health, health information system, medicines and technologies and vaccines, but we still have a very long way to go.
Indeed. We will come back to that and some more in this particular session. But let me go to coordination, which is a really challenging thing. Coordination seems to be so. I'll go to Dr. Clara Ijembi first for her perspective. Every time you think healthcare in Nigeria, you think people quarreling with each other. Pharmacists, doctors, junior staff, senior. I'm a management teacher, and this is the dysfunctional organization. Teams. I have a favorite writer around this gentleman called Patrick Lencioni, the dysfunctions of the team. Why is the healthcare system so apparently dysfunctional in terms of coordination of things and people working together as a team? So, Dr. Ijembi, you and then Mazi Samuhuabunwa on the same subject.
Okay, thank you very much for that. I think when you look at the coordination, first we
perhaps you can adjust your laptop also so we can see your face more. We're seeing more the area around you. Wonderful, thank you.
Okay. So when you talk about coordination, I think first and foremost, even constitutionally, when you look at the legal framework, we have problems. We are told health is on the concurrent list, even though some people argue whether it's on the concurrent list or not. So it's usually coordinating things across the 3 tiers of government has been very problematic. So let's start from there. Each layer of government, even if you formulate a policy at the national level, you cannot expect that all the states will buy in and begin to implement. And there's little control at the federal level to force states, to implement policies, no matter how good the policies are. So it's like we are running, is it 38 national health systems now? The federal one, the 36 states plus FCT. And if you add the layer of local government, everybody doing his own thing. So coordination has been a major problem. And there's been a lot of talk on how to improve coordination across the tiers of government. A solution has not been found. So it's frustrated implementation of policies. That's number one. Number two, even within the Federal Ministry of Health, there's little coordination across departments and across programs. Oftentimes, I say programs, they put concrete walls across themselves, especially programs that are well-resourced. There's little information sharing, and there's little integration, if at all. So for example, I'll give an example in the Federal Ministry of Health. You take reproductive health. When you look at safe motherhood, there is a division or whatever looking after that program. And then you find another unit looking after VVF, vesicovaginal fistula. And all of them, the same determinants. And the interventions are essentially, to prevent it are the same. But VVF people, that suffer complications from childbirth, and maternal self-motherhood are preventing maternal death and all of that. And maternal death is the end product. VVF people are not talking with maternal mortality or self-motherhood people. And they are planning around the same issues of prevention of maternal death and how to address backlog of cases. So these kind of things across programs, across departments, people are not talking. And when you now come across agencies, the National Primary Healthcare Development Agency, for example, that are responsible for at least implementation of PHC, and for the Federal Ministry of Health people, for policy, but you find them, taking over some implementation things, and there's a lot of tension. So these kind of things are frustrating program implementation or policy implementation. Then by the time you leave those levels, you now come to, within professional bodies. The tension there is out of this world. There's professional rivalry, there's all sorts of infighting. And by the time you look at it, it's even affecting patient care. Common example now, you go to a health facility like the teaching hospital that I know. Previously, when a doctor walks into the health, the ward and goes to see the patient, the nurses all come, you do the round, you see the patients together, instructions are given, are taken, and everybody works towards implementation. Now the doctors come to do their rounds, the nurses are sitting at their station. They are not under doctors. The doctor wants to send a messenger or a lab ward attendant. They will say they are under the nurses and not the doctors. And at the end of the day, it's the patient that suffers. Even if you want to get a screen to shield the patient, it's the patient's relative that will go and bring it. The nurses are sitting looking at you. So that kind of professional tension and rivalry, it's adversely affecting the quality of care that we offer the patients. It's also affecting, I think, the collective visioning and working together to achieve our goals and objectives.
Now, the people who have overcome these problems elsewhere, I mean, obviously they don't have 10 heads. How did they overcome them, and why are we not applying the same things that have led to better coordination?
I think, for example, in terms of overcoming the problems, for example, let's say Ghana, their health indices are a lot better than ours. And it's because they have a single government health system. We don't have state governments implementing their own policies, local governments doing whatever they want. You have a single health system, and you plan centrally, and you can ensure implementation up to the local level. So is it possible to have a constitutional amendment so that we have a unified healthcare system, not the kind of healthcare system that we have?
Okay, we'll come back to that, but I want Mazi Samuhabu to come in here. I mean, and this is at several levels. The problems of pharmacists, doctors exist, but it's even many years ago, I wrote a case study on the essential drugs list. When Professor Oligwe Ransom Kuti was minister, we all know what happened with the World Health Organization's EDL, the concept of generics being available in government hospitals. And I recall very clearly that the way it was interpreted literally led to the folding up of the pharmaceutical industry as we know it in Nigeria. I wrote that case study more than 20-something years ago. Mazi, are you still there?
Very much there.
Oh, okay, please. Coordination, what's the challenge? What's the problem?
Look, Pat, as we are discussing all this, my heart continues to bleed. I feel like crying because just like Professor Lambo said, he's older than, maybe slightly older than us, and he thinks he has spoken enough and he's tired. We also should be tired of speaking. When Dr. Menaka came to government as Minister of Health, one of the things he did was to empanel a team. We came from people like the late Professor Lebute, Professor Kinkube, myself, and many others very distinct, to sit down to work out a system and a plan that can work or that could work. But no sooner than things changed, policies kept changing, or even where the policies were made, they were not being implemented. But let me go to the main issue you asked me. I think there are three things dealing with coordination. Number one, which is number two and number three, if you look at it, is lack of leadership. Lack of leadership. It's the issue that we face, because all the problems of TJB has spoken, all that we have spoken, just shows there's no leadership. National, sub-national, tertiary, there is no leadership. These are symptoms. Pat, you said those who did it somewhere, do they have 8 heads? They don't have 8 heads. The critical thing is that they have leadership. The problem is leadership. I mean, leaders can do good, they can do bad. So if we have good leaders, they do good things. If we have bad leaders, they do bad things. So leadership is an issue, and that is where the whole thing hinges. There is no reason that we should be the way we are if we had good leaders to coordinate and to work out a system that works. So that's the primary thing, lack of good leadership at different levels. Now, when we have had some smarting of coordination, you find that the leadership shown, and that's the next problem. The next problem is lack of team spirit. Lack of team spirit. And this was caused, with due respect to everybody listening here, when Professor Oligwe Ransom Kuti came, with all the good things he did, he was the one who dismembered the unity of the healthcare team. When I became a pharmacist, an intern pharmacist, I entered the teaching hospital, and my colleagues who are house officers were 1 or 2 steps ahead of me in the hospital in terms of grading, financial grading, salary, and allowances. In fact, at one time, I was leading both the medical doctors, physiotherapists, and all of us to go and meet with the director of administration to present our case. We were united. There was no schism, there was no division, there was, like Oliko Ransom Kitty came. One of the good things he did a lot of good things in primary healthcare, but he took out doctors and put them on a different scale and kept the rest of the health team in another scale. That's when this saw the foundation of this disunity came on board. Today, it has almost become a policy that every health institution must be headed by a doctor. So I'm 40 years or 42 years old pharmacist. In practice, I come to the hospital or any health institution, and my son, who just graduated in medicine 3-4 years ago, is posted to that place. He becomes my boss. That is absolute injustice. And that's why the nurses, the physiotherapists, the medical lab scientists, and all of that rejected it. And that's the major thing. If we don't call it the name, we cannot solve it. Medicine or healthcare is a teamwork. In the university, sometimes we all start with the same basic training, and then we begin to differentiate, to different specialties and special areas. We need to bring that spirit. We need to bring that spirit. And what did I call you? What did I mention, Professor Lambo, to you, Pat, when we were discussing this program? I said he was a non-health, he was not a medical doctor who headed the ministry, and he managed the ministry differently. So we need to differentiate administration and management from clinical practice or from specialties of healthcare. Those days, there used to be a director of administration who handled administration in hospital, and then the different professional groups had their leadership. I think we need to restore to that. If not, the competition will continue, and the unhappiness by some segments who feel they are maligned. You come to a hospital, chief medical director is a doctor. The medical advisory is a doctor. Everything is weighed against other healthcare professionals. That is a principal issue. Thirdly, is poor regulation. The poor regulation is due to lack of regulation. I mean, the poor regulation is manifesting in what was said even by Dr. Menakaya, where you have all kinds of quacks and people crossing lanes, people practicing as if they were doctors, people practicing as if they were pharmacists, people practicing as if they were other healthcare professionals. Sometimes it's the healthcare professionals themselves crossing lines. Sometimes it's people from outside who have no training. Now, all these things are man-made. They can be regulated. If a pharmacist practices like a doctor, a medical doctor, he should be fined. If a doctor practices like a pharmacist, he should be fined, except where there is insufficient manpower. Then they do what they call task shifting. You can ask a doctor to do more or less, a pharmacist to do more or less, but it's with understanding that it's for the benefit of the patient. It's not each person usurping the other's responsibility in a way that is uncoordinated. These are the issues. And Pat, these issues are not beyond human solution.
Well, thank you very much. I think it's very important to get to this so that we can begin to engage at the level of solutions. Most of our conversation will end up being about solutions, but it's good to lay the groundwork first. And we've talked a lot about these levels of government. Dr. Jembi spent quite a bit of time talking about, that 38 different healthcare systems. Perhaps Dr. Jide Idris can come in at this point to say, what happened in Lagos? How did Lagos manage to get things better? What are the issues in coordination between Lagos, Abuja, and perhaps local governments within Lagos in terms of planning and delivering healthcare solutions?
Can you hear me?
Yeah, okay, I can hear you now.
Thanks, Pat. And I think thanks for inviting me here. It's interesting listening to everybody say his own bit. Bottom line from everybody, what everyone has said. I mean, Professor Lambo mentioned all the functions of the health system. The key one that everybody has been saying is leadership and governance. If we don't get leadership and governance right, nothing else will function properly.
Yep.
That's it. Can you hear me?
Yeah, sure.
Yeah, that's the issue here. Now, coming back to Lagos, and I will tell you part of it. One of the things, the achievement we had in Lagos was basically due to Professor Lambo too, when we went for National Council on Health. So during this time, we decided on health reform issues, health service, I mean, health system reform. And we sat down at the national level and came out with that protocol. Is that protocol I took back to Lagos and domesticated for Lagos. But you see, leadership and governance is very key because it was when we decided we're going to do this, I mean, the reform in Lagos, we said we need to restructure the whole system because we could not continue with the same system. It's what everybody has been saying. We have a lot of plans, we have a lot of programs, policies, the problem is implementation. You mentioned the problem is coordination, the problem is regulation. All those come under governance. If you don't structure the governance properly, you cannot get it right. And last bit, people have asked me this question many times. How did you do it in Lagos? And my answer has been that if you, as a commissioner for health, do not have the backing of your principal, you can never succeed. And the only way you can have the backing of a principal is that you need to sit down with your principal and explain to him what you want to do. Because to me, there's a lot of ignorance in the health sector. Everybody assumes you know, but you don't know. You may say the policy here. I can ask many people here what the policy is, how to explain the policy. Many people cannot explain to you. Take, for instance, again, the major problem we have in this country right now are the local level. That's a structure. We're talking about primary health care. But who are those who are going to implement at the primary health care? This is where you need the brains. This is where you need the expertise and the expertise like that. Who are the people who govern the thing? They don't know. They still rely on this thing. So for Lagos State, I think we took the thing and we were lucky that we had a backing of our principal, the governors as at that time. They showed commitment to the health sector based on our advocacy to them. And the last thing I will say is that you see, any government that does not value life, the value life of the citizens, will never fund the health sector. Take, for instance, what has happened in the last few weeks over these NSAS. Look at what happened in Lagos. In 2 days, key infrastructures in Lagos were destroyed in 2 days. And yet, the economists talk about infrastructure without talking about human resource issues, social security issues, social network. These are the issues that you mentioned it again. Health and all this. If you don't discuss that, all the infrastructure can be killed in any time. So we need to have a proper governance structure. What are the roles and responsibilities of each chair of government? And everybody must know who is going to lead, who is going to monitor, who is going to, so many things, what's coordination. And everybody must understand their roles and responsibilities. Where you don't have that is a problem.
Let me put something to you, and to be fair to you, as permanent secretary, I used to see you in places. You were pretty good at bridging the gap between the political and the civil servant role, because you really cannot be effective until you can get your political leaders to understand the value of what you are curating. It seems to me that part of the problem is that technical people, whether they be civil servants or what we sometimes call technocrats, just say, well, these politicians, that's what they have said. That's what. How activist should a technocrat be in trying to get political leaders who should actually be playing the lead role in defining these things? What's your thinking about your experience?
serious you are, how specialist you are, whatever specialized you are, you cannot get anything achieved. So you need to come down and explain to your principal, these are the political leaders, what you want to do in the language. They need to understand. Again, if you are lucky, you have people who are willing to listen to you and they give you the free hand to do what you want to do. If you are a specialist, your specialization has a limit because the people who determine the policies and all are the politicians. If you cannot get across to them, then you haven't done anything because you cannot perform your function properly. So you see, there's a need for advocacy. Everybody needs to understand. You need to get everybody on board. You understand me? You have to go to your governors, your fellow commissioners, even the House of Assembly, because the governor himself is under serious, whatever, the pressure. So many people have different ideas to him. And if he's not careful, that's why you have to have that rapport between you and your governor, whoever is your principal. You need to understand and let him sell to him your plans. Explain to them what the health. You see, people do not fully understand what the health sector, what the health sector is, or what the health system is. Everybody feels that once we build a hospital or big battery, that's the health system. That's just 20% of the health sector. You can build the health sector, you don't even have the staff to work there. You don't have the drugs to do everything like that. You don't have the policy or programs to even implement all those. So, of what use? So, you need to educate your principals. You need to educate your colleagues, even our colleagues, doctors, nurses. For instance, Sam mentioned all this. It's a function of that health. Our health system is one that is filled with conflicts. And that's where leadership comes in. You must be able.
Yeah. Let me turn to Dr. Gonsalves, who succeeded you in the ministry.
Key issues in this.
And kind of pose the same question with a particular emphasis on training of healthcare professionals. We find it in many aspects of Nigerian life. I deal with priests a lot in various churches, and we assume that the priest leads the congregation, knows everything. Priests might not have the first knowledge of how to manage human beings. We assume the same thing for doctors. We assume the training of doctors usually doesn't prepare them for management, leadership of these kinds of teams. What should we be doing about how to train healthcare professionals so that everybody recognizes that this is a team? I'll give you another example. In the university systems in some countries, it's not the best academic in the university who is head of the university. Usually there are professionals who focus more on university administration. In some places, that's different. How should we be approaching healthcare in terms of preparation of people and the question of coordination?
Thank you very much. Like I said, when we talk about health sector reform, it's not a one-time affair. It's a continuous process. We did it in Lagos. We decentralized a lot of our systems in Lagos. Put some people in charge of hospitals, give them mandates, give them opportunity to do. But we also realized again that having decided that many of them, they don't have the management experience. This is where it comes in again. And look at the health sector now. It has changed completely. It's not like we used to have again. You need to manage your hospitals, you need to manage the system, everything like that. So there's a key element, there's a serious need for managers' expertise. This is where, again, our curriculum, training of medical doctors, the curricula need to be changed completely to reflect modern time. We need to, to be able to function now, management is key. Because now you have different players, different resources. I think, for instance, during the Ebola thing, the first time I realized the issue of, what do you call it again? We had a lot of resources. It's all these donor agents that came up with all these logistics management. How do you move facilities? How do you move systems? How do you move drugs? How do you move consumables and that kind of thing? This is where I realized the need for, logistics management in the health sector. It's a management tool, and it's very, very much required in the health sector. Same thing like how do you manage your facilities? How do you coordinate all the various things? Like the doctor is not trained for management. But if you have a doctor who understands the system, who also is trained in management, it becomes, key. So management is key. So in this day and age, with COVID, with NSAS and everything like that, there's a need for total review of our curricula, our medical school curricula. Trainings must be changed. Management is key. Also, so are key. Financing is key. The students now must understand what the health system is like, not only limited to clinical care. The health system is much larger than clinical care. And if you don't realize that, we cannot make any impact in the system. You keep turning doctors, diseases keep changing, people need to track data, all those things. All these things are people who do so. They need to coordination, systems, everything like that. The doctor is not trained for that. You understand me? So there is a need for us now to change our overview, the views of the health sector completely to reflect modern times.
Okay. Let's get a perspective from Dr. Titilayo Gonsalves. In experience, especially how do we hold people accountable for their roles? Because the confusion in systems now in healthcare delivery is such that we don't know who to hold accountable. The system seems to be so significantly dysfunctional. Who are we holding accountable for what? What are the deliverables from the various professionals in the system? Is she with us?
Thank you very much. I just want to acknowledge my honorable commissioner, tireless commissioner of Lagos State, who gave us. I'm heading as the administrative officer in permanent secretary there. We had a lot of doctors who have. No,
perhaps you can turn off video so that we can hear you better.
The healthcare personnel who had some issues. There were always disciplinary committees, because we can say for sure things in the health sector whereby maybe medical treatment is not given right or
Give me that girl.
Yeah, we're having challenges hearing you.
Okay. Yes, so we found that accountability was a big problem in the sense that when you want nurses, pharmacy,
It's not.
I can hear you clearly, sir. Hello, can you hear me?
Okay, yes, all right. Yeah, you were breaking. But
hello.
Yes, we can hear you
Hello.
now.
Hello.
Can hear you now.
Hello. Can you hear me? Hello, can you hear me now? Hello.
Yeah, we can hear you.
Okay. Now, the political, like I was saying, the political system does not help in terms that we are doing now, does not help in terms of discipline. Now, we know that the government largely top-heavy politicians. A lot of them decide who you hire. And so when you have issues, you have people who are not doing what they should do. There's a father somewhere will come and tell you that, touch not my anointed. So when you have this going on in the system, it does not allow you to get good results from the staff. And human health resource is backbone to health. You cannot run the system if you do not have people who are manning the hospitals the way they should. And So that is one of the issues whereby was a great challenge to us.
Okay. All right. I'm afraid that Dr. Gonsalves is frozen up, but let's then return to the ministers on this subject of coordination
Very good.
and policy.
Very good.
Perhaps Professor Lambo might be good to get your reflection. We see that there's complete management failure in the healthcare system in Nigeria. There is a certain, I guess, failure to understand that it's about management.
Yep.
And we are not getting the management professionals to help organize the sector. There's an entitlement mentality of the professional players who don't recognize the limitations of their skills in some areas. There's failure to train them appropriately. And so we have this very dysfunctional system. Who is accountable? Who should we be holding accountable? Why are the political leaders not articulating the issues? We've had elections here. Nobody even mentions healthcare. You just finished one. Obamacare has been an issue in America for years now. That has been central political conversation. And if you recall in my introduction, it's either that our politicians don't understand what they are in business for, because primary to human progress, the great escape, health, education. My view, if people have a good education, the right ones, they have good health, every other progress will come to them, because those people who have know-how and know why and are well will make for progress. But we focus so much on infrastructure, this, that, and we don't get progress. How do we begin to hold people accountable in terms of the direction that healthcare delivery is traveling in our country?
Thank you very much, Patrick. First, I'm happy you brought me back into this, the discussion on coordination, collaboration again. I identify myself with what Clara, Mazi, and Idris said about this issue. But it's a very, very important issue. And until we address this, we are not likely to make much progress. Now, as Clara said, I think this coordination thing is in many directions. There is the issue of the coordination among the three tiers of government. Secondly, there's that between the public and the private sector. Thirdly, you have coordination with external actors, because in our health development, we get inputs from our external partners. And there is a problem of coordination, coordinating their inputs into our efforts to develop the health sector. Fourthly, you have the problem of coordination among the health workers. This really is coordination and collaboration, which is a big, big problem, like Mazi said. And then you have the issue of coordination across directorates and agencies. And they have profiled solutions to some of these problems. I'll just highlight three of them. I certainly agree with Idris, and I think Mazi said it, leadership, the importance of leadership, governance. And when we are talking about this leadership part, it is leadership at all levels. And I would say it will start from the highest level I mean the President of the Federal Republic of Nigeria. Then it goes to the states, and then the sectors, and then the various departments, and so on. And even when you talk about the unions of the various health workers, leadership there is very important. So we must tackle this issue of the leadership, either through election or through appointment or whatever. The second one, which I think Clara mentioned, and I think is very germane, is constitutional or legal provision. If we don't have the right constitutional or legal provision in place, we'll be wasting our time. And this is one of the lacuna that we have. Take the 1999 Constitution. It will not help you in terms of what are the functions, what are the roles and responsibilities of the various levels of government. Where this is missing, then you are going to raise the problem of accountability. Okay, so the 1999 Constitution, I hope the revised one will do something about this, has not addressed this problem. And I want to play the tape back, that when I was minister, we realized that this was a problem. We realized that until this problem was solved, we will not make progress. That was why we came up with the issue of having a national health bill, which we developed in 2004, my second year in office. And we got FEC to ratify it. But what came out eventually as in the National Health Act is so different from the initial draft that was approved by Federal Executive Council. Actually, my first draft that I took to Council was returned to sender. And the reason was because I was trying to say, look, since there is no constitutional provision, we could smuggle in, we could address this problem and state the roles and responsibilities of the three levels of government. When I took it to FEC, I remember what the president said. He said, Itayo, this is very beautiful, but it will not work. And I was disarmed. I said, why, sir? He said, we're in a federal setting and we cannot legislate, in certain areas for the states and so on. So we had to remove that. Where we spelled out the form. If you look at the National Health Act that has been passed, that we are now implementing, we only spelled out the roles and responsibilities of the National Health Council, the Ministry of Health, and so on, not doing anything about the state or so. So there must be a way we address this in the Constitution. When you clearly state the roles and responsibilities, you'll be able to address the issue of accountability. So the third one that is missing about coordination is in Nigeria, because one of the elements of, one of the things, the strategies for implementing primary health care is intersectoral health. Intersectoral action for health. I'm sorry, I was guilty of this. We had no forum when I was minister, and I doubt if they have today, for really promoting intersectoral action for health. So these are some of the key things we need in order to be able to address this issue of coordination. Now, let me leave that and come to the guy from Lagos. I'm sorry, I've forgotten your name, who was talking about management. I was almost tempted to clap for you when you were saying that. Where we are, and in whatever you do, whether at the private level or corporate or whatever, management is so key. You have all the resources available to you. The way you manage those resources will go a long way to determining the outcomes that you are going to have. And I noticed when I was a minister that one of the things, I have always known this for a long time, that the people who are in charge, who are the heads of our major parastatals and for delivering healthcare, namely teaching hospitals, federal medical centers, they had little or no knowledge of management. I think Mazi mentioned it. Ghana, what they have done, because they have the same experience, is now to come up with a very noble idea. You have a technical person managing or overseeing the technical functions of the hospital, the teaching hospitals. But then they created, a post, can't remember what it called, chief or something officer, who is in charge of administration. And that is in line with what we used to do once upon a time, but not before Abraham was. When I was in Ibadan, in UCH, in University of Lagos, we had director of administration. So we were even calling them governor. You had a governor in Luth, you had a governor in Ibadan, house governor. The one in Lagos happened to be from my area. So I think it is time. Ghana has dealt with this, like I said. They created, chief, I think they call, I can't remember what the title they gave him, but that person is the head of the hospital. And it's a non-medical. If you have a medical person that has the qualification, oh, that's a double advantage. And Pat, let me give you a secret to you. I was monitoring the performance, and I had indicators for monitoring the performance of my medical directors and chief medical directors. And lo and behold, my top two chief medical directors were those who, apart from their professional degrees, had acquired MBA. Maybe it's a coincidence, but I think from that little sample, I could generalize that. Look, I think it's commonsensical that the more, if you have your other skills and you acquire management skills, certainly you are going to manage better. If you don't manage better, then the discipline of management is irrelevant. You should scrap it. So I think there must be a way, and I had way back about 20 years ago, I've been preaching. I know that the curriculum of the medical curriculum is jammed up, but there must be some element, there must be some dosage of management into the curriculum. Or if I want to be selfish, a little bit of economics will not do any harm. Okay? Because these are relevant things now, and a little bit of law too. I know they have legal people in, but you yourself, before you can even, understand what your legal officer is saying, and so on and so, you must have a little bit knowledge of what he's saying. So I totally agree that management must now be seen as very important component of health and medical education.
Right. Well, thank you so very much. Let me turn to something else that comes out whenever I try to research challenges in sectors of the economy, healthcare being a very important one, is the place of goal displacement. Let us call it politely goal displacement. But the word is corruption. The amount of corruption that is involved in the administration of healthcare, the waste motivated by corruption. I was talking to one former director in the Federal Ministry of Health who said, look, I think it was the avian flu time or something like that. Monies that came, and the fact that logically you shouldn't spend, there wasn't as much of the flu going around, but people, because they we're going to profit from it, spend a huge amount of this donor-supported money buying drugs that eventually just were never used. How do we put in place systems that reduce this inclination to take private goals and displace public goals, which is again, like I said, nice way of saying corruption. The costs, I don't think is being measured well, because in many cases, lives are being lost because of this kind of thing. How do we create an ethics sensitivity in healthcare management in the country? Because, you know, it's costing us a great deal. How do we put in place consequence management for misuse of resources? We say the resources are not enough, but the way we use the ones that are made available is so suboptimal that we don't get as much for the buck as we could have gotten. Perhaps we can start with Dr. Menaka, looking at this subject. How do we deal with so important? People will just tell you about frustrations in the Federal Ministry of Health with things that have gone wrong because the motives are primarily, corruption driven.
But I think this is a very important topic in healthcare delivery in Nigeria. Mostly running of hospitals and other places like primary healthcare and others. I've already mentioned that money is not adequate through the government to run any of these areas. But also I have to talk about the wastage, the system, how we adulterated the system in medical care. I joined the medical service in Nigeria in 1966 after working in Britain and in Italy. And I found that the system then was very clean and very good. There was a proper hierarchy. There was a system where the pharmacist is in charge of pharmacy, and the nurses are under a matron or something and takes order from there. And there's a proper cooperation between the medical director and all the other services that you have in medical service. The most important thing is the patient. The patient is the principal thing why we create hospitals. Today, the patient does not come in. Patients are asked to go and collect their drugs, buy gloves for surgery, buy everything from outside. And those things, most of the time, are supplied. Before we have private practice, and I was from government to private practice, and from private practice, I became the minister. And I found so much differences that happen now compared with when we started. A doctor has a hospital of his own and works in the government and earns salary, and goes on strike if the salary is not forthcoming. And probably going on strike gives you more patients in the private place. These are the things that we have to check. If we don't check them, we can never have a system. The worst is that in the teaching hospitals, all the doctors in teaching hospitals have private hospitals. Why can't you have corruption? Why can't you have any of these things coming in? All right? Most of the time, the patient is in the teaching hospital or in the government hospital, and is directed to go to see a doctor in a private hospital. Yes, we have a Tamura medical practice in a place like Britain. A doctor is accredited to many hospitals and earns money from those hospitals. but he concentrates on his work. We are talking about administration, we are talking about hierarchy, we are talking about everything, who is in charge and who is not in charge. To a patient, these things are not important. What is important to a patient is to get well and go home. We don't consider it anymore. And a good doctor is the person who creates a short distance between the patient's home and the hospital. And that is giving the proper medical treatment and you go home. What we are doing in Nigeria is not seen anywhere. You talked about Ghana, you talked about anything. The principal things we do to run a proper hospital is to get the patient to go home. And he must have to be done. We must have to sit down and recalculate. In the early 70s, after the Civil War, there was a rule that people should not establish a hospital without being licensed. The hospital must be inspected and found adequate for the treatment of patients. Today, we compete with hairdressers for space to call a hospital. We compete with everybody. We have no respect anymore. The doctors, if you see them, it's money that they're talking about. And two, how do you expect a medical doctor who is denied of his salary from time to time to put his maximum in the hospital? The doctor has systems we talk about.
Yeah, what could we be doing in terms of solutions to end all of this?
What we do in science of pollution. Dr. Lambo, I know him and he was quite experienced in the WHO and all the international areas. People are there like in Nigeria. We should sit down and draw a proper policy for medical care in Nigeria. As he said, which is true, doctors come in and have different policies. A doctor has been in this country, talked about primary health care and discouraged secondary and tertiary institutions, ran them down, and people started afresh. This is the country we are in. The administration is very simple in medical care. You don't need to have a degree in administration to treat a patient, to send the patient home as recovered or at least make him feel looked after. When Dr. Clara or somebody was talking, I nearly wept. I didn't meet this when I was in the hospital. And when I was a minister, I didn't know about this. That others are no more there in the hospitals. There's no hierarchy in the hospital. In every society of men, for it to be a society, somebody must be in charge. And others must obey. But the person that is in charge should not be a tyrant. He must have a system where which all these professions in the ministry must meet from time to time to discuss the patient. I use the word the patient, but when I say patient, I mean the hospital. When I was there as a minister, we have a Monday meeting in the morning, every week on Monday. And we have a report from each department to tell us what they did in that department and what they will do in the new week we have entered. It's worked for us. We were harmonious. People were quarreling from ministry in the ministries. The minister is quarreling with the permanent secretary and quarreling with his junior minister. We didn't have that in my ministry when I was there. Because we met every time and talk to each other. And it's very, very important. We have to coordinate. We are there for the patients. We are there for the health of Nigerians, not for the aggrandizement of ourselves. This is what is important. And it should be made a policy. It should be made there. It should be written down. Drug supply and all those things are under the pharmacist. The laboratories should have their leader. The nurses should have their leader. And all these people will be coordinated together and make them work. And in a society where there are no sanctions, what do you expect?
Yeah, you you had Dr. Titlayo Gonsalves who was permanent secretary in health in Lagos, talking about anointed, people's anointed and all of that. There seems to be a complete breakdown of discipline. You cannot discipline people who have not done what they should do because they have some political godfather.
That's what I call sanction. Most things we have in Nigeria, the laws, even most parts of the constitution are wonderful, but they are not implemented because there are no sanctions. People do what they want and get away with it. You hear somebody caught today that it was embezzled the ABCD amount of money. You hear it in the newspaper, you have it in the newspaper, you don't hear it anymore. It just goes into oblivion. That's what we need to do. There's no way, no place in Nigeria you can say things are happening well. Nothing. We should have the right people in the right places. We should have employed people. When we talk about corruption, we talk about money only. But money is not the corruption. Employment is corruption. People do what they're supposed to do is corruption. Nepotism is corruption. Every single aspect of life, you can have corruption in it. We don't take one aspect. Yes. Not money. Everything said it took so many billions. And all of them go into billions. And nothing happens at the end. So why should the next person not collect the money if the first person that embezzles so, or put all these relations in somewhere is not punished? Let us rewrite. Let's fix Nigeria. Let's fix Nigeria. All the problems will be over. We are so much gifted by God. We had everything. Very well educated people. Everywhere you see Nigeria outside Nigeria, they are regarded as the best workers, hardworking, very well educated, and all those things. When we come back here, it's the mediocres that take over. Why should we do that? It's not only medicine. When people hear what we are talking about, they will think that medical care in this country is a different kettle of fish. It is not. Every single thing needs to be reorganized, and we need to do that. When people talk about the Constitution, has there any meaning?
Yeah. Okay, very quickly, Dr. Lambo wants to say something. Yeah.
Yes, please. I thank my senior colleague for what he has said. Now, let me, Pat, I know you know, but let me just underscore this. That this issue of waste, of fraud, of corruption, or whatever name we want to give to it, is not peculiar to health. I'm sure we know that. It's really endemic, and is getting more and more serious. It's now a 4th grade cancer, and God help us. Now, let me play the tape back. When I was appointed Minister of Health, and I have been relating with the ministry for at least about 25, 30 years before I was appointed minister, in one way or the other. I remember a few friends who told me that I wish you luck in your ministry. I said, what the hell do you mean? He said, do you know the name of your ministry? I said, of course I know. Why won't I know? He said, your ministry is not Ministry of Health.
No, when it stops, they're going to call another.
Pardon?
Sorry.
And they hear me.
Please go. Huh? Okay. Professor Gunlesi, yeah, okay, but please go ahead.
Okay. You said it's not Ministry of
don't
Health, it's Ministry of Health.
Ministry of Health.
H-E-L-L. And I said I reject that name in Jesus' name.
Amen.
Now, what am I saying? Patrick, I have almost given up on this issue. Not only giving up, I'm giving down also on this issue of corruption in Nigeria, because it's getting worse. And that is what is going to kill us. It's already killing us.
Yeah.
So, I mean, we can talk all we want to talk, but there are certain basic things that we need to. Leadership. It comes to leadership again. We must have people leading
But
by
the
example.
government came to office on a fight corruption platform.
Well, Patrick, we will discuss that at another level, not at this level. It is easy to say some of these things, but is it happening? And I dare say boldly that it is not happening. So, because we need to have dedicated leaders at all levels. The person at the apex, the person in charge of the various sectors. Because if I'm not stealing money in my ministry, and I find, or they report and I investigate somebody who is stealing, of course, you know what I will do. So that leadership and leading by example is so critically important. Secondly, I think my senior colleague mentioned this issue of regulation. You know, there are regulation and enforcement of regulation. Where the regulation is broken, there should be no sacred cow. Okay? And you can only have that if there is true leadership. Then the third one is this procurement process. I'm following the process. Procurement process. You are right. I think somebody did a study on drug supply. And they said in many countries, if you order drug, ₦1 drug, $1 drug, at the end of the day, what gets to the facilities or to the patient is only about 25 cents. And you have paid $1 because of this corruption. You know, so that process, which they say we have a procurement process in place. Actually, this was developed over the last, my colleague, Obi, was due process lady. Well, I think it was working then. I don't know whether it's working today. That's what I'm saying, that the level of seriousness in implementing these initiatives and policies vary from one time to the other. And the fourth one, don't laugh when I tell you this solution. If others fail, or maybe along with the other three I mentioned, is the reorientation. You know, changing our mindset, the mindset of a typical Nigerian, to say that when you are put in a position of service, God has put you there. That is your mission. If God gave you that job, then you are carrying out, it is not only when you are doing something in church or in the mosque that you are carrying out God's mission. So you should have in mind that you have a creator. And whatever you are doing, you should do things to to glorify that creator. If we can change the mindset of everybody to that, then your goal will be what you are doing, what you will do in order to serve the people and not to serve your pocket. You can serve your pocket and at the end of the day, be very, very unhappy. But when you serve your people and there are clear evidences that you have served your people, you will have that internal satisfaction. That's my own experience. People may call you a fool when you get out of it. I remember when we finish our I mean, we closed shop in 2007, and the house monetized to us. I was still owing 36 million on it. And I told a number of friends, and they said, but you were Minister of Health for 4 years. I said, you don't have to tell me, I know. It's like saying you must be a fool. And I said, I would rather be a fool. Yoruba people will say, not your humanity you won't share. I am the son of Lambo. He's not alive, but I don't want to spoil that name. But more importantly, I'm the son of my godly father. I never, even if Prophet Isaiah had told me that I would be Minister of Health in Nigeria, I would say, well, you prophesied about Jesus, but this one is not going to work, because I had no political connection. But that came my way. And I felt the only way I could glorify God was to do things to the best of my ability. So we need a reorientation. Maybe we need the church, but of course, some of the churches is a no-go area, because even if you steal the money and you take the money to church, they will not ask where the money is coming from.
Yeah, it's a lot of work. We need, there's a lot of work to do in our country.
Yeah.
And by God's grace, we will engage it. Now, one of the reasons that we have this series, as I said, is for young people to learn. And so I have co-hosts who are young people, teenage, 20, and I want to probably turn to them first to see if any of them have questions to ask of the panel. And then I don't know if Professor Gulesi I heard something like he was trying to make a comment. Is Professor Gulesi on the line? Did he want to say something? When Professor Lambo was speaking, I think I heard
yes, he was trying to
some sound like he was trying to say something. It's not easy at 90-something to, be still engaged, and we value that very much. So we thank God for that, and we know how challenging it can sometimes be. But in the absence of that, let me turn to, is Claire there?
Yeah.
Question.
Yeah. Good afternoon, everybody. Thank you so much for being with us. Particularly, Professor Lambo, I'd really like to thank you for taking us through the history, because as my dad said, one of the most important things is for us to understand that. And so it's really great to actually go through the motions and get a sense of where we've been. And so my question right now really would be looking at our current system and also looking at the roles that Nigerians have played in other countries. People have this notion that if all the Nigerian doctors in the NHS were to leave, the whole system would fall apart. And so what do you think is the role of the diaspora and medical professionals in fixing the Nigerian health issue? What is the role that they can play or they should be playing?
Yeah, okay, a very important question, I think, there from Claire, because part of my thesis in looking at development is that the diaspora is a critical turnaround point. I mean, in Japan, the Meiji Restoration and Japan's ascendancy post-Meiji was driven by the diaspora returning from Germany and Europe generally. We see India and China's ascendancy significantly impacted by the diaspora. And here we are, knowing that Nigerians, for example, are the most highly educated migrant population living in the United States of America. And many of them are outstanding healthcare professionals in the United States and in the UK. But the Indian diaspora went back and created an industry and health tourism, medical tourism. We're all now spending millions and if not billions of dollars from Nigeria going to India. How can policy facilitate the Nigerian diaspora doing the same thing for healthcare in Nigeria, making it a destination for health tourism? Any of us can speak to it, any of us on the panel.
Yes, Patrick, can I come in?
Oh.
Sorry.
Yes. Lambo.
Okay, yes.
Yes, I think Titi, I think you raised a very, very important issue. I'm in Atlanta right now. My doctor here is Lagos trained, and he has won many awards in not just in his hospital, in Georgia, in his own discipline. Young boy, he turned 50 last year. And there are so many of them. In one of the hospitals, the chief medical director until recently is also from Nigeria. He trained, in Lagos with my doctor. So they are all over the place. And that is what makes one sad, that you have all these Nigerians here and things are not working at home. Let me tell you, when I was minister, they have an organization in UK and they have an organization in the US. The one in UK is called MANSAG. I met with them in Manchester. Indeed, we drew up a memorandum of understanding, about how we can use their services. I came over to the US. I met the group here, big meeting, AMPA, they call it AMPA here. And again, we did exactly the same thing. But this is part of what I'm saying about policy somersault. When we left, I don't know what happened. And I still see these people, and they are very eager to contribute. Let me give some credit to government. That at least right now we have a parastatal? Yes, where this lady is from Lagos.
Abika
Dabiri. So, and then I know that in my former ministry, there is a very visible health desk. I think it's a unit, but to me, it should be a department, not just a unit, because of the Nigerians that are in the diaspora, that are in the health area, that are distinguishing themselves. So we should have policy, it's not just a policy, and then translate this policy to strategic plan for involving these people, particularly in the health sector. I have spoken with many of them. They say they can arrange so that about a month or so, a year, during their holiday, they won't mind coming to work, in one of the teaching hospitals. So we can tap on this very, very fertile ground here.
Okay, terrific. Dr. Titilayo Gonsalves was going to make a comment.
Oh, Pat, can I come in? Oh.
Yeah, who is indicating?
Jide Idris.
Okay, yeah, sure.
Well, you see, one thing I want to ask is that if you could create an avenue to discuss leadership and governance in the health sector, go a long way in this country.
I agree.
And to make nonsense of it. Many people don't even understand the nitty-gritty of leadership and governance. Everything we talk about here today revolves around this issue, including the issue of diaspora. The people in diaspora, just like the Prof said, I used to attend AMPA meeting almost every year some time ago. After a while, I stopped. The people in diaspora have the expertise. They're working in an environment that is structured, that has very good governance, rule of law. They have processes, they have culture, they have ethics. We don't have that here.
Yeah.
So if you bring them here, it's like taking them from a culture they are used to, bring them here, they get lost or they get frustrated. That's reality. So see, leadership and governance is key. Where those two fail in this system, that's where policies come in. That's where coordination comes in. That's where planning comes in. That's where management comes in. That's why accountability, transparency comes in. That's why ethics comes in.
Yeah.
This is where process comes in. And you see, you have public administration system here, the bureaucracy in our systems. Some that are outside the purview of the health workers. It's a serious issue. I think if we don't deal with leadership and governance in the health sector in this country, we will never make any progress. I rest my case.
Thank you.
Thank
I will
you.
take Dr. Titilayo Gonsalves, and then we'll go to a break for 1 minute and then come back and I'll take questions. Yes,
I think
Dr. Gonsalves.
Okay, yes, I just wanted to comment that I find this platform very invigorating and I'm energized by it. But you see, what I have noticed and through the years is that we come together like this. We speak about the history of this platform. We have ministers, missionaries, we have people who are, you know, knowledgeable and know a lot about health. The government, a lot of the information there, very well trained, good human that to make a change. If we are called upon to volunteer our time, just to come around so that we get a stipend to sit down for sitting allowance, or we get a pack. What happens a lot in the government budget for things that really don't matter. But to sit down and say, how can we really move this country forward? We all complain about our president, but then we are part of the problem. We complain about the fact that there's not enough budget. But let us come down to brass tacks. You know that health is not only about absence of disease and limitation of disabilities, but also the fact that you need to have well-being, physical, social, and mental. I want to say that if we run a survey, not everybody will qualify. What I'm trying to say is that we can start locally. The filth in our environment, if we can take that away, make sure that back to the old days whereby the environment is clean. Of course, if you have a clean environment, they are going to get less prone to disease. There are things we ourselves are guilty of, which is not about money, which is not about budget. Can't we try and do what we can change around ourselves and raise a voice for enforcement for these basic things, rather than continue to meet and discuss and nothing tangible comes out of this? We need to have short-term, medium, and long-term goals to address and really make an effective change in this health sector. Thank you.
Thank you very much. I think that ultimately we must go in that direction. The reason that this series will go for 6 different episodes is so that we can get specific implementable outcomes that we will put forward for any policymaker to consider, for even trying to deal with reorientation. Because it will surprise you that many people who are involved in these practices don't actually realize how much damage they are doing. In fact, they may know that it's not good, but they don't realize the true consequence. And so the national orientation thing that we've talked about, a program for doing it sector by sector. We brought on Dr. Garba Abari, who is supposed to be running the orientation agency, to some of these programs, so that he will understand what the issues are, and there can be a collaboration between volunteers from the civil society, private sector, and his agency to help do these things that will transform. But I think Professor Gulesi is able to, or still raising his hands. Can we get him to speak? If not, then please, anyone who wants to ask a question while we go to this 1 minute break can raise their hands, indicate by going to the raise your hands icon and click in. Professor Gule, see if we can have you unmuted so you can say some words.
Mine is 90 something at the lab. Okay.
Okay, I think we'll go to.
Can you-
Okay, yes. Okay, yes, bro.
Can you hear me now?
Yeah, very clearly now. Yes.
Yes, sir.
Okay, it is to say that I found it very interesting to listen to all that has been said today. But I want to tell you that my hope is that everybody who has spoken today will do something about what is said and not just speak. Action is better than words. I want to suggest to you, a relevant issue is that a few days ago, I heard that some members of the House were complaining about the amount of money that our president spends in treating himself abroad, which I think is very relevant to this. I hope he's listening. No British Prime Minister or member will be flown to America for treatment. It's only in Nigeria that our head of state is not ashamed to go abroad to receive treatment. When he gets there, he will find that Nigerians are practicing in the hospital where he's treated. Therefore, I hope that what we would be trying to do, let me tell you another thing. All our problem in Nigeria are the people who are known as politicians, not professionals. These politicians, in the sense, they are enemies of the people. I make bold to say that. In the sense that they are very selfish. They want to live in Lekki, they want to live in Abuja, but when they die, they want to go and be buried in their villages, the villages where they have done nothing to improve. They don't want to be buried in Abuja or Lagos. You see, we build our houses from the roof, whereas when the local government, 700 I think of them, become the basis for the development of Nigeria, then these are problems. We'll have a solution.
Absolutely, I fully agree with you, bro.
But I do hope that each of those who have spoken today would be prepared. I hope it is somewhere in the Constitution, when you have served at the federal or local or state government level, you should have a duty to go and work for your local government for 1 year. It should be obligatory. You see, because when Nigeria consists of effective, some road work is going on. I live in Shagamu now, and this is where I'm going to be buried when I die. Some road work is going on in front of my house as I speak. And when I talked to the engineer, he told me that the state government hired a private engineering company to build road for them. You see, when the state itself does not have the equipment or staff, the engineers, Nigerian engineers, to build roads, they go and hire private people at a cost. Of course, they know that they are not going to live in the village. So, for goodness sake, for the sake of tomorrow, let me hope that each of those who have listened to me tonight, I told you I was 97, so I don't have much longer to go. But in the interest of my own children and grandchildren, let us build a Nigeria where, when you live in Umwa here or in Sokoto, you don't have reason to envy the person in Lagos because your community is well developed. The roads are now, you see, you drink, if you don't buy water now, you can't drink. You see, if the roads are good and people can live in comfort, if they can drink water, if they can drink tap water from the public. I saw a place yesterday called public toilet. When I was a boy in school in Lagos, You could take water from public tap. There are no such things anymore. You see, everybody is manufacturing water. You have to buy water to drink. The good Lord that provides the water under the ground does not sell it to us. The politician of today, if he has the opportunity, he will sell air. Yes, he will sell air because he knows that when the money comes, they monopolize the money. You see, the governor sits on the money that will be given to the local government chairman. Therefore, I would like to see my friend Untitled Lambo as chairman of the local government because he knows the problem.
All right, sir.
Thank you so much, Prof. I think that it is so well said. The next session we will have will actually be focusing on primary health care. And thesis on this. We here at the CVL created what we call neighbors caring for neighbors. Rooted on how to get more wealthy neighbors to adopt less well-off neighbors. And primary health care is the basis of that solidarity, human solidarity networks. And I will speak to that when we have that episode. But let's take a message from some people who are helping us keep this going, and then we'll come back and take questions.
"51 food and agro-allied product brands, 21 subsidiaries, hundreds of industry accolades, over 150 billion naira in backward integration projects, over 14,000 dedicated employees and hundreds of business partners. It's 2020, and Flour Mills of Nigeria is celebrating 60 years of feeding the nation through impact investments in critical food value chains, job creation, and community development. Our journey of national commitment began in 1960, when our visionary founder, George Kumantaros, filed an application to establish and operate the premier flour mill at Apapa, Lagos. His vision to create a household flour brand has guided Golden Penny, our flagship brand, in becoming the iconic symbol of top quality products that is accessible across Nigeria. The company has evolved into Flour Mills of Nigeria PLC, Nigeria's biggest food and agro-allied group, with extended operations in oil and fats, feed and proteins, starches, sugar production, agro-distribution, bag packaging, and logistics services. Our high-performing backward integration programs in sugar, oil palm, cassava, and grain production are helping Nigeria on its self-sufficiency journey to food security. Going forward, we will continue to fix our focus on creating opportunities, empowering communities, and sustaining growth. Flour Mills of Nigeria, celebrating 60 years of feeding the nation every day.
All right, welcome back. Some indications of questions, and we'll be moving quickly to rounding up. Dr. Tolu Ademujimi. Tolu is calling from Ondo State. Participating from Ondo State, not calling. Okay, yes. So go ahead.
Good evening, Prof. It's been a while. Thank you
Yes,
so
indeed.
much for what you represent in Nigeria and how you have been able to mentor people like us for almost 20 years now. It's been such a privilege, sir, to be a mentee. Now, having been in the health sector myself for quite a number of years, a little over a decade, and I have my own experiences. I was in primary healthcare for 5 years before I crossed over to the Contributory Health Commission of Ondo State, which is the health insurance agency. Now, my worry, of course, I've typed it earlier. It's about, so as part of the many issues in healthcare, one of them is leadership and governance, which thankfully Dr. Jide Idris has been able to clearly highlight. Because for me, my question therefore now goes, if Dr. Clara, for instance, had suggested in her fantastic contribution that she's worried about the dysfunctional state of the healthcare system in terms of leadership and governance, and then she thinks that we should rather have a unitary system of managing the healthcare. Now, my question is, because I'm worried that I disagree respectfully with that. How do you manage a system of 206 million people, their healthcare from Abuja, where, for instance, we have different, disease burdens and prevalence? I come from Idore, where you have Idore Hills, for instance, and in Idore, most of my people there are cocoa farmers. And so, which national policy from Abuja has talked about chemical poisoning from cocoa in the last 60 years? None, because everyone has been about HIV, malaria, and what have you. So therefore, I think, that if you keep saying we should keep running a unitary system for healthcare and every other aspect of Nigeria, we cannot solve the peculiar issues of healthcare amongst us. So my question therefore should be, why are we afraid to devolve leadership and governance of healthcare to the subnationals? And Canada is a beautiful example. 37.7 million people. And if you check their health sector practice, they will tell you that a large percentage of their leadership and governance issues in healthcare are devolved to the provinces, Quebec, etc., so that you can have a better coordination. Why are we in Nigeria, therefore, afraid to devolve leadership and governance in healthcare and other spheres of our lives to the subnationals? That's my question. Thank you, sir.
Thank you very much. I think we will then turn quickly before the answer to Dr. Chika Nyaetok. And after that, then we'll have a response from the panelists, I guess, beginning with Dr. Jembi.
Good evening, Prof.
Good evening.
Good evening to respected and distinguished panelists. I'm a former country medical director of Unilever Nigeria and currently have a health advocacy company called Healthwise Concepts. My question is, why can't we think of a bottom-to-top approach to making healthcare services, quality healthcare services available, starting with the poorest of the poor? One of the speakers earlier said one of the problems with the national health, health insurance scheme was that they started with people who could already take care of themselves, instead of with people who could not take care of themselves. Our population is mostly young people, and from the statistics that we have, many of them are unemployed or underemployed. So these are the sort of people that we should be thinking of, people in the rural areas, people who cannot, who live under the so-called poverty line. So if we're going to talk about making quality healthcare accessible and without financial hardship, with defined minimum standards available, then we should be thinking of starting with those who can't afford to get it for themselves first, and then build it up from there. Because it looks like in Nigeria, we always start with the easy things. Just make it easy. We already have an easy way of getting to maybe people who are in government, people who are in organized private sector. But those people that you don't get to see, but make up the majority of the population, hardly ever get the care. So my question is, how can we, in all the things we have said here, definitely leadership and governance, like Dr. Jide Idris has said, if you don't start there, then you're not going to make any headway at all. But when we look at all the things we've talked about, eventually everything comes down to the patient, like Dr. Menakaya has said to us. So we are thinking of patient-centered care. And that patient that should matter is the most vulnerable person in the society. So how can we, whatever changes we're making at the systemic level or at the whatever level, how can we start with the people who are most vulnerable and get the changes to start from that level going up? Thank you.
Thank you so very much. What brilliant questions, both of those. Let me then go to the panelists, beginning with Dr. Ejembi. Any response?
Thank you very much for that question. I think sometimes when you look at problems, we've made attempt at the evolution of our healthcare system, especially primary healthcare, during the era of Ransom Kuti, 1988, civil service reforms. And things don't seem to work. If we are to improve on health, we have to invest on primary healthcare, and the local governments have responsibility for that. And that is the level that has the least capacity and the least willingness to even want to do anything. And currently, I think, in spite of the autonomy they are being granted, a lot of them don't seem to have even funds to implement anything. And I can speak for Kaduna State, simple things to provide logistics for COVID-19 response in their respective domains. Most of them would say they don't have funding. So the capacity is not there, the willingness is not there, the funding is not there, and there's absolutely no coordination. And if you formulate policies at national level, the implementation is quite problematic.
But Dr. Ejembi, permit me to challenge you a little bit here. Isn't that an opportunity? You see, part of what has happened is that, and I go back to what Professor Gunlesi was saying. What has happened is that the way that our politics has managed local government administration, I know a friend, a governor who sent his T-boy to the house. What is his T-boy going to do in the house? This is the kind of politics that's devalued us. If you retire as a permanent secretary and you go back to your village, you retire like Professor Gulesi as a professor of medicine, you go back to Shagamu, you retire as a general, you retire as vice chancellor, and those cadre people become the ones who become the councillors who run the local government. The cumulative experience there will be better than what you have in Abuja. And they can run such things much better because they know the disease prevalence in that area, you know, and so on and so forth. Don't you think that that would be the way to go?
Yeah, if it can happen, great, but will it happen? And when will it happen? You know, and in the short term, what can we do? So let's look at countries where they are making headway. What lessons can we learn from there that we can infuse into our system to get the turnaround that we are talking of? And that's why I brought the example of Ghana to challenge us. Let's look at it. You know, they are just down the road. Their life expectancy is 10 years higher than ours. All their health indices are a lot higher. And the proportion of funding they put into the health sector, I think they've made the Abuja declaration of 15%. So can we look at those countries and find out, you know, what are the ingredients of success? I just brought that as an example. They went unitary and they're achieving. We can look around other places and then harness the success factors and see how we can use that, you know, to inform policy directions in this country. That's one. Number two, I think let me just quickly comment on the health insurance. I think what the lady said is absolutely right. We seem to take the easy way out, and we have not made any significant progress. I think the 2017 National Health Accounts showed that only 1.6% of the Nigerian population or the health expenditure is covered by health insurance. And the data is actually, you know, I got it from the NHS when I went to ask them a few things. So we have had health insurance for all these years. In fact, when we look at it, they said the journey started around the 60s, and we were still at 1.6%. Just because we just focus on the informal sector and formal sector and at the federal level. Now with the state health insurance, I think it's expanding. But obviously we need to find a way of bringing the 70–80% of the informal sector that has the greatest need. If we are to talk of, achieving universal health protection and ensuring at least 90% financial risk protection. And that is the only way to go, to begin to invest in bringing in the informal sector, and there should be cross-subsidy for the rich to be at least offset some of the costs of care for the informal sector. That's my
Okay, lovely. Thank you so very much. Any other person on the panel who wants to respond to those?
Can I say something?
Okay, yes, Dr. Menaka.
Dr. Idris. Dr. Idris.
Okay, then we'll take Dr. Menaka and then we'll come to you, Dr. Idris.
Okay, all right.
Yes, Dr. Menaka. Yes. Unmute. You need to unmute yourself. Unmute, we're not hearing you. Aha.
Yeah, you are hearing
okay,
me.
Good.
What she said is the right way, and it's the only way we can service healthcare delivery in Nigeria. We know in Germany some years ago, there was an election, and Bismuth was contesting for the chancellor of the country. The topic was healthcare insurance for the country. And he staked his agenda on healthcare and was able to convince everybody the importance of healthcare. By simple definition, it's getting money from the rich to treat the poor, to look after the poor, because it's a percentage of earning. And it's a shame that healthcare that was started in 1999 today is 1.5% or thereabout in a population of over 2 million people. It's expected by now everybody should be on healthcare. And despite corruption and other things, it will run more smoothly than it's being done today. We have a lot of work to do. The conference is to ginger us to know the way we are going to. It is very necessary that people sit down. But you have started this. You have to produce papers to show how these things can function. About diseases in the primary health care. When I was there, we produced a book on primary health care in Nigeria. And every single town in Nigeria was mentioned in that book, showing the peculiarities of the primary health care problems we had in those areas. Some people condemned it, some accepted it, but it's a fact that it will help everybody. Somebody talked about disinfectant poisoning and all those things. They were all there in that book. But the rivalry in the ministry suppressed it. Because in Nigeria we have problems. We're an amalgamation of so many groups, and the groups have not been harmonized to be a country. We have problems. If we harmonize Nigeria to be a problem, to be a country, everything will run smoothly. Corruption will go, poverty will go. But today, nobody is making any effort to do that. What we have today is, I'm from ABCD. I attended I have so religion. This is harming us a lot. When we talked about Nigerians in diaspora, I wanted to say something. I was there and I was asked, ordered to go to US and launch the Nigerian physicians in diaspora in US. And the president ordered me to attract them to come back to Nigeria. And I told Mr. President, I'll do every other thing, but I will not convince anybody to come back to Nigeria because they'll be so frustrated. The first question is, where do you come from? What religion do you belong to? And know what that will mean to the person coming back, and the person will go back. It's not the same as India. India built their economy through diaspora. I was in a conference in Hague, and there was a newspaper we had in front of us. An Indian was arrested in UK, where he embezzled some money and was being tried. And I told the minister from India, look at your country and you are talking about Nigeria. He said, no, there are differences between us and you. We still abroad to develop our country. Nigeria is still in Nigeria to develop other countries. We must have to be a country before we can get all these things right. We must speak to each other. We must come together and find solutions. Health insurance is the key to health delivery, to health care in any country now, and it will be like that for a very long time. So the lady that brought it up, I congratulate you, and we must speak about it and must meet about it, and the percentage should be 100% Nigerians should be on health insurance, and then we move forward. Pat can go.
Thank you very much, Dr. Menakaya. I think that, okay, a comment from Professor Lambo again, and then we'll be rounding up. Two more questions here we've not brought on. We'll do very, very quickly. Yes, Professor Lambo. Dr. Idris was also going to make a comment, right?
Yes, sir.
Okay, yes.
Should I go ahead?
Yes, please go ahead. We'll go to Professor Lambo after you.
Yeah, so the first question was the evolution of leadership and governance down to the states or local government level. Personally, with the current structure we have here, I don't see any problem with that. It only depends on the will of the level of government. Even the state, the will of your governor and the people running the ministry. The local government is just the will, because it's very clear there. So what we have, if we can government at those levels of care, we have, we don't seem to have any problem. I think that's what we try to do in Lagos. Well, not fully successful, at least we made some progress. Now, on the issue of a bottom-top approach and the health insurance scheme thing, my experience is that, in Lagos State, we spent a lot of years trying to plan for this health insurance, which we virtually launched about 2-3 years ago. Even as at that, it's slow thinking. And my take is the challenges involved in establishing a health insurance scheme for a state or for a country. You know what has happened at the national level. At the state level, it's not easy, especially in a situation where very few governments fund the health sector. To have a proper health insurance scheme, the government must invest in that sector fully. And this is why it comes in. Should it be mandatory, should it be contributory? With the current level of funding in this country, in most states, there is no way you can run any efficient health scheme without all those who were talking about corruption, etc. Take for instance our tax administration systems. How many of us pay tax in this country? Even the ones we pay, how are they managed? It's from this little amount of money, tax that you need to fund that scheme. How do you manage even the pool of funds when you will have that? I know that is a problem now because the people in government feel that, once you have a large pool of funds, it's money to spend. They know that money is supposed to use to plow back into that system. But you need to get more people into that health insurance space. Service delivery is something else. We're talking about our infrastructure, human resource issues, everything like that. These are major challenges that militate against proper health insurance duty, apart from the issue of administration and management and corruption. But there's no doubt that's the way to go. and this is what again, you can retool our system to address this. Let the government fund the system. Health is not cheap. We have a huge level of poverty in this environment. Very people cannot, very few people that can pay for the health sector. So government must come in. Take for instance in Lagos State, part of that law we passed, but that there must be some equity fund that is at least 1% of the revenue coming to the state should be brought back into that scheme, and that scheme should be managed. The idea was to bring that scheme out of state government so that it could be properly run. It's running.
Part of my take with this, I've argued for years that we need to rethink tax policy in our country, where we can use specific use taxation and have governance around specific uses, such that you're paying some tax, just like paying for a toll gate, and you know that the money is for the maintenance of that highway specifically. So I think with many things, including healthcare, that there are ways that we can configure specific use taxation with governance systems that then ensures more efficacious deployment of those resources in those areas. But these are issues I've argued for the last 30 years. Nobody seems to listen to me anyway. We've got to move quickly and take a comment from Mazi. We're going back to Professor Lambo. Mazi, 1 minute, and then I don't know if the questions we're still able to take any. I think maybe we'll respond to those later. Yeah. You need to unmute. Okay. Yeah, still muted. Okay. Yeah, you're still unmuted.
He's unmuted. Yeah, he is Lambo.
Yeah, Professor Lambo is still unmuted. Yes.
I've learned a lot today already.
He's muted.
Okay, yeah.
He's still muted.
Okay, Sam, let's take you now.
All right. Thank you, Pat. I got knocked out for a while.
Okay.
But I think for me, I just need to make these following closing comments. I think we have established it because, Pat, it is not that nobody has heard you. You can know that you're not the only one speaking. Books have been written, conferences have been held, summits have been held, and all these things we have spoken today are in books, are in government archives. There's nothing new. It's leadership. I mean, look at Lagos. We use Lagos as an example, and I'm here. I'm glad our former commissioner is here. Lagos has shown example that when good leadership is in power, things work better. Some of those issues I raised at the beginning, in Lagos, most of them have been resolved. There's a greater level of cooperation. But I think there are two areas I want to mention. You asked somebody about accountability. Accountability is critical. When we're looking for more money, when we're looking for new ways to get things done, there is, for example, in the hospital system, we have the drug revolving fund in the tertiary institutions today. But these funds are supposed to be self-regenerating so that we can have medicines and consumables. Because when patients go to the hospitals, there are two primary things they are looking for. Talk to a doctor to know what is wrong with them and to go away with some medicine. Now, most times, if they get to the best doctors that do the best diagnosis and they don't get away with medicines, they do not put value to what the doctor has done or what another health professional has done. So availability of basic drugs in hospitals is something we can solve even today. And our past leaders, including the Professor Lambos and the rest of them, started the drug revolving fund. Today, this fund is now being mismanaged by the mismanagers of those hospitals who, rather than use the money to repurchase or pay pay healthcare providers, they are using them for other things. As I speak to you, Pat, pharmaceutical companies are owed more than 17 billion by health institutions, mostly federal and the Federal Minister of Health and some state governments. Money they supply, goods they supplied for them to use to run the hospital and regenerate funds. They have used the money and wasted it. And nobody's holding anybody to account. I've taken this matter to the Ministry of Health. I've shown them all the list and all the hospitals and all the institutions that are being owed. I'm waiting for action. These are verifiable debts. Now, if the DRF cannot work, what else can work? Finally, I also believe that we should begin to think about research and development. I'm not sure, I don't know why it was mentioned when I was knocked out. We should stop being a nation that is waiting for the whole world to provide solutions to our problem. Why can't we, for example, look for ways to integrate traditional medicine and alternative medicine to our health repertoire, the way it is being done even in Ghana, so that we can have people trained as traditional health doctors or traditional health pharmacists and nurses that can run in parallel lines in hospitals with the orthodox doctors and orthodox pharmacists. That way you make healthcare more accessible, more affordable, and something that our people are used to. This wholesome adoption of Western way and everything about Africa and everything about Nigeria has not been good enough for us. It's about time we turn them to something that is good. You saw what happened in COVID-19 when we were trying to get COVID organics from Madagascar. What our research institutes and researchers could have done here, but without appropriate support. So these are things we can do even in the short term, where we get for the appropriate leadership and all the changes that we have spoken about in this meeting. Thank you.
Well, thank you very much. I think that we have to go. We are way over our time budget, but it's been a very, very important subject.
Can I just have 30 seconds, please?
Sorry?
30 seconds.
Okay.
Thank you very much. I hope people are hearing me now.
Yes, okay, yes.
Okay. Pat, I commend you for this initiative. But I think I heard you say that it is not a one-shot discussion we are having.
For the next 12 weeks, we'll be discussing health and...
Okay, very good. So in the light of the issues that have been raised and so on and so forth, mine is more of a suggestion that we should think of dealing with the following issues. And when we take an issue, that will be the subject of discussion for that day. The first one, just like most of us have mentioned, leadership and governance. The second one is health financing, which will bring a full discussion on national health insurance, the journey so far, by the time we were living in 2000, well, although we've been talking about it since 1962, Dr. Moses Majekodumi was the first one to talk about it. Nothing was done until the 80s. And even the decree was signed in 1999, but in terms of concrete implementation, nothing was done until 2005. But even by 2007, when we closed shop, the coverage was between 5 and 6%. So you are right. If the coverage today is 1.6%, there's something fundamentally wrong. And it is very disheartening giving birth to a baby, and then you see the baby dying. Mazi, you were a member of the board, governing council, and you know what happened at that time. And today we are talking about coverage of only 1.6%. So I think the second issue we should discuss is health financing. Under that, we will talk about the journey so far with National Health Insurance Scheme, what has gone wrong, and what we need to do. Under that, we will be able to talk about this universal health coverage, whereby we think of how do we cover the various groups of people. I agree with the person who suggested that the vulnerable should be covered. But you can't cover them with insurance. There must be a way. There is a financing mechanism known all over the world for covering such people. It has to be budget financed. So that will be a topic. Then the third one is we come back to HRH, Human Resources for Health, which will allow us to talk more about, discuss about these people in diaspora and about curriculum changes, if necessary. Changing the curriculum of particularly incorporating certain things that are missing, which are useful into the curriculum of some of these categories of workers. So that's the third topic. And the fourth one has to do with health service delivery. And under that, we will focus attention, or we will discuss the issue of primary health care. I'm not saying that the other components of health system is not important, but these four are very critical. And if we don't make progress in these four areas, we're just wasting time. So if we can make our future discussions revolve around each of these for a session, and then at the end of it, because Mazi said it, what we are saying is, in writing, is somewhere, that kind of, I agree with him. That's why I was saying I was tired. People lately came to me and said, talk about health insurance. I said, what do you want? I don't like saying the same thing over and over again. You have the document showing many of these things. The problem is go and implement those things. Yeah. But vested interest will not allow them to do that.
And that's, I guess, part of the challenge, that there must be a, if you will, marketplace of ideas that is ready to be actionable, that challenges the vested interest, that shows to the general public and everybody that this is what is in the interest of the common good, that vested interests are fighting. That's why civil society needs to be active.
Absolutely.
And my hope is that with these conversations, we'll begin to arrange those things. But we must get people to act. Like Professor Gulesi was saying, we all need to act. But let me close by thanking you all so very much, from Professor Gulesi, Dr. Menakaya, Professor Lambo, Dr. Zidris and Gonzalez, Dr. Ejembi, Mazi Samuwa. It's been really an educative afternoon, and I do hope that most of you can join us again. Our very next topic, actually, 2 weeks from today, same time, primary health care. That is the one that I would like to engage with first. And I am truly hopeful that this series of conversations can help us produce true progress. Thank you all. God bless, and have a great week.
Thank you very much,
Patito. Thank you so much.
Hey,
our celebration here.
Thank you very much.
Thank you.
Thank you, Professor Lambo.
I see you from the
Thank
Philippines.
you, Mazi.
Well
God
done,
bless
sir.
you.
Well done.
So we continue our celebration here.
We'll continue, sir.
Okay.
We are with you. We are with you in spirit.
Thank you very much.
God
I will send some cake to you.
That would be nice.
I appreciate it, sir.
Bye-bye now.
Bye-bye, sir.
Yeah. Huh? How do I leave? Where are you? Okay. Yes, I said so.
Subsidiaries, hundreds of industry accolades, over 150 billion naira in backward integration projects, over 14,000 dedicated employees, and hundreds of business partners. It's 2020, and Flour Mills of Nigeria is celebrating 60 years of feeding the nation through impact investments in critical food value chains, job creation, and community development. Our journey of national commitment began in 1960, when our visionary founder, George Kumantaros, filed an application to establish and operate the premier flour mill at Apapa, Lagos. His vision to create a household flour brand has guided Golden Penny, our flagship brand, in becoming the iconic symbol of top quality products that is accessible across Nigeria. The company has evolved into Flour Mills of Nigeria PLC, Nigeria's biggest food and agro-allied group, with extended operations in oil and fats, feed and proteins, starches, sugar production, agro-distribution, bag packaging, and logistics services. Our high-performing backward integration programs in sugar, oil palm, cassava, and grain production are helping Nigeria on its self-sufficiency journey to food security. Going forward, we will continue to fix our focus on creating opportunities